Welcome to the presentation, Infection Control. I'm Catherine Rogers, the Infection Control Nurse. We will discuss the importance of infection control and why we need to all be consistent in following CDC, OSHA, and our hospital policies and procedures. Infection control prevents the spread of infections to clients, employees, and visitors. It is a well-known fact that clients, patients, residents, etc. become sick in healthcare facilities. This is called hospital-acquired infections, or HAIs. The reason for this is because your body is immune to bacteria, fungus, pathogens in your own living environment. But when you go into a healthcare facility, your body is introduced to germs, bacteria, pathogens that your body does not recognize, and so you become sick. This is why it's also important to keep up with immunizations. Immunizations help to protect against infections. Transmission of bloodborne pathogens and other organisms. Infection control principles. We will discuss the infection process, what we need in order for someone to be sick. The first thing we need is a causative agent. We need a reservoir, a portal of exit, a mode of transmission, portal of entry, and a susceptible host. What interventions can you think of that would break the infectious chain? We will go through each one of these and you will have a better idea. The causative agent is a bacteria, a virus, fungus, or protozoa. So you need one of these in order to have an infection. The reservoir is a place where the infective agent can survive and possibly multiply. The bacteria or pathogens need a warm, dark, moist place in order to multiply. We can find these places in humans, in contaminated food, water and toys, sports equipment, insects, animals, and soil. Next is the portal of exit, the path by which the infective agent leaves the reservoir. It can do this through the respiratory tract, the intestinal tract, urinary, genitourinary tract, open wounds, blood, and bodily fluids. The next one is the mode of transmission. This is the mechanism of transfer of the organism from the portal of a new susceptible host. In other words, if I'm sick and I pass it to you, because you've been busy working a lot of shifts, working a lot of hours, you're tired, you haven't been eating right, you become the susceptible person because your immune system is down because of what you have been through recently. I can do this through direct physical contact, where I wipe my nose and shake hands with you. I can do this with a respiratory droplet, coughing and sneezing without covering my mouth and nose. Contact with blood or body fluids. Indirect contact, I wipe my nose and then I hand you a piece of paper before I've cleaned my hands. a needle stick injury, ingestion and contaminated food or water, contaminated dust particles, contaminated objects, insects, or animals. And then the next one is the portal of entry, the path by which the agent enters the susceptible host. It can enter into your respiratory tract, your intestinal tract, urinary, genitourinary tract, open wounds, mucous membranes, eyes, mouth. I cough or sneeze. Your mouth is open, you're yawning. The bacteria comes from me to you and then sits on your mouth or your eyes where your mucous membranes are, and it sticks. And then because it's warm and moist, it starts multiplying. Or maybe you rub your eye and you have an infection in one eye and your other eye is itching, and you go to rub the other eye, and so you transfer the infection from one eye to the other. And then susceptibility. This is the susceptible host, a person or animal lacking in resistance to the agent. You know, back when the Indians were here in America and we had people from other countries coming, they had never seen things like measles, mumps, or any of the diseases that these pilgrims brought with them. So a lot of them got sick and died. Infants, elderly, and debilitated, persons who are ill, children who are not fully immunized or have underdeveloped immune systems, persons taking certain drugs that lower their defenses against germs, such as a person taking chemotherapy for cancer. That breaks down your immune system so you're more susceptible. Persons with underlying disease conditions that lower their defense against other germs. We can break the chain of infection. Employees are to wash their hands in the following situations: before handling clean patient care equipment and supplies, before serving food and after picking up used meal trays, between contacts with patients, after using the restroom, after handling soiled linens, after removal of gloves. You know, it's very important when you're handling soiled linens that you wear gloves so that you don't get any of the urine or blood or whatever is on the linens on your hands. But after you remove the gloves, it's a good idea always to wash your hands because there might be a little bit left that touched your skin. So be sure and wash your hands. When washing your hands, you need to do this in the following order. Turn on warm or cold water. Advance the paper towels. Apply soap. Scrub hands for 20 to 30 seconds. Like if you were singing the song ABCs, that would be about 20 to 30 seconds. Ensure areas between fingers are washed. Clean fingertips by scrubbing against palm of opposite hand. This causes friction, so it helps to remove any bacteria. Do not allow the hands to touch the sink because the sides of the sink are contaminated. When rinsing, hold your hands in a downward position so that water runs from wrist area to the fingers into the sink. Use clean paper towels to dry hands and then dispose in appropriate container. Use a clean, dry towel to turn off the water and open the door. We're going to stop here, and I'm going to show you how to wash your hands properly, and then each one of you is going to demonstrate to me that you understand how to wash your hands. Now, we all know that washing our hands isn't always feasible. So we can use an alcohol-based hand cleaner for antiseptic or antiseptic towelettes that are provided. When alcohol-based hand cleansers or towelettes are used, hands are washed with soap and running water as soon as possible. When caring for clients with diarrhea or running stool, use soap and water, not hand gel. There are certain bacteria that the hand gel will not kill. E. coli is one of them. Standard precautions. All employees admitted to WSH are on standard precautions for the duration of their stay. So we ask, what are standard precautions? Standard precautions are what we use. There are appropriate precautions to prevent skin and mucous membrane exposure when contact with blood and other bodily fluids or any client is anticipated. Gloves are worn for touching blood and body fluids, mucous membranes, or non-intact skin of all clients. Also for handling items or surfaces soiled with blood or body fluids. And for performing venipuncture or performance of any procedure where it can be anticipated with blood or other body fluids will be evident, such as giving injections, your SQ, IM, or ID injections. Gloves are also work when serving or picking up meal trays. And then gloves are discarded after contact with each client, and then we wash our hands. Now, I teach standard precautions as a very important thing. It doesn't matter whether a patient has been diagnosed with a disease such as E. coli, HIV, hepatitis. I don't worry so much about people with these conditions because most of your employees are very careful about making sure that they wear gloves when someone has a bloody nose or is incontinent of urine when they're dealing with patients like this. But you need to remember it's also important for patients that you do not know. You do not know if they have been not diagnosed yet. And so therefore, it's important that whoever you're working with, that you wear gloves and then wash your hands if you're going to be dealing with body fluids. Standard precautions also include masks and protective eyewear or face shields are worn. They protect you against droplets of blood or other body fluids that are likely to be generated. and also to prevent exposure of mucous membranes of the mouth, nose, and eyes. Gowns or aprons are worn when splashes of blood or other body fluids are likely to occur. A survey shows 77% of hospitals provide education on hand hygiene. And we need to really work on this to make sure that people are paying attention and doing what we're asking. Hypoallergenic gloves, glove liners, or powder-free gloves are available to those employees who are allergic to the normally provided gloves. Personal protective equipment is considered appropriate only if it does not permit blood or other potentially infectious materials to pass through to or reach the employee's clothes, undergarments, skin, eyes, mouth, or other mucous membranes under normal conditions of use and for the duration of time the protective wear is used. If a piece of clothing or protective wear is penetrated by blood or other potentially infectious materials, then items are removed immediately or as soon as possible. All protective equipment is removed prior to leaving the work area and is placed in the designated area or container for storage, washing, or disposal. Hands and other skin surfaces are washed immediately and thoroughly if contaminated with blood or other body fluids. Hands are washed immediately after gloves are washed. To prevent needle stick injuries, we do not recap needles. We do not purposely bend them or break them by hand. Remove from disposable syringes or otherwise manipulated by hand. Used disposable syringes and needles, scalpel blades, and other sharp items are placed in puncture-resistant containers located as close as practical to the use area. Special care is taken when removing used lancets from fingerstick devices. The one-hand method is to be utilized. And when you become a CNA, they will teach you how to do this one-hand method because you will be doing glucometer checks for the nurses to help out. But this is not until you become a CNA. Biohazard sharp containers are what we put our needles and lancets and razor blades and also glass serum bottles into. And once they go into one of these containers, we do not try to take them out. Never put your hands in the container and only fill 2/3 full. Standard precautions, we use syringes with built-in safety devices that are available for use. Also, employees who have exudative lesions or weeping dermatitis do not do direct patient care nor handle client care equipment until the condition resolves, and keeps open areas covered to prevent infection. Standard precautions also talks about eating, drinking, applying cosmetics or lip balm, and handling contact lenses by employees. This is prohibited in work areas where there is reasonable likelihood of occupational exposure. Medical treatment rooms, laundry, patient rooms, utility rooms, medication rooms, food and drink are not kept in refrigerators, freezers, or cabinets or on the shelves. Countertops or bench tops where blood or other potentially infectious materials are present. The hospital also has isolation precautions, And the Wyoming State Hospital uses the CDC's guidelines for isolation. Isolation precautions consist of two tiers. Standard precautions are designed for the care of all patients, regardless of their diagnosis or presumed infection status, and is the primary infection control strategy. Standard precautions combine the major features of universal precautions apply to blood, all body fluids, secretions, and excretions, whether or not they contain visible blood, non-intact skin, and mucous membranes. And then we have transmission-based precautions. These are specifically for clients with known or suspected epidemiology, important diseases, which is spread by airborne transmission, droplet transmission, or contact transmission. These are designed to prompt implementation of transmission-based precautions that are based on clinical symptoms and conditions, while a more exact diagnosis is being sought. Nursing may implement isolation precautions when a specific disorder is diagnosed or suspected. Orders for specific isolation must be obtained to continue these precautions. Once ordered, isolation precautions are not discontinued or changed, except as ordered by medical services. Airborne precautions. We use these to reduce the risk of airborne transmission of infectious agents. Disseminated through airborne droplet nuclei of evaporated droplets suspended in the air or dust particles containing infectious agents. Special air handling and ventilation are required. Transfer to another facility until transferred, moved to a private room. Limit exposure to client. Wear a mask and patients should remain 3 feet away if possible. Client wears a mask while being transported. Employees not immune must avoid contact. Can you think of any examples of airborne precautions? Any diseases that we might have that would require this type of precaution? Herpes zoster in an immune-compromised client or with disseminated disease. Measles is also an airborne precaution. Tuberculosis, when they talk about a negative pressure room, this is why they're talking about it, is so that a person can be in an isolation and we can go in and take care of them without fear of getting TB ourselves. However, we have to wear the right equipment. And then varicella or chickenpox is another type of airborne precaution. Then we have contact precautions. This reduces the risk of direct person-to-person or indirect person-to-object transmission of infectious agents. Including standard precautions, clients should be placed in a private room. If not available, contact medical services or infection control for options. Employees need to wear gloves during the course of providing care, remove gloves before leaving the room, and wash their hands immediately after leaving the room. Avoid touching any contaminated surfaces. Gowns are worn if suspected that clothing will have substantial contact with client or services, and also remove the gown before leaving the room. Transport the client as little as possible, preventing contamination. And equipment is cleaned and disinfected before use on another client. Can you give some examples of contact precautions? We would use contact precautions if we had a person who had an abscess with major draining, cellulitis with uncontrolled drainage, Clostridium difficile infections, conjunctivitis, or MRSA. The equipment that the patient in isolation should remain in the room until patient is released from isolation precautions are a blood pressure cuff, a thermometer, and an O2 sat monitor. This is so that we can provide vitals for this person to see whether they're improving with our treatment. And then we have droplet precautions. Droplet precautions reduce the risk of droplet transmission of infectious agents. Contact with conjunctivae or mucous membranes of the nose or mouth with large particle droplets. Droplets do not remain suspended in the air. Special air ventilation is not required. Private room is recommended. If not available, contact the medical services or infection control for options. A minimum of 3 feet is maintained between the indirect or infected person and other clients or visitors. A mask is used when less than 3 feet if possible for client care. Client wears a mask when being transported. Now, can you give some examples of the types of diseases that we might be looking at for droplet precautions? How about diphtheria, German measles, Haemophilus influenzae, meningococcal pneumonia, mumps, mycoplasma pneumonia, parvovirus B19, pertussis, and pneumonia adenovirus. So these are some reasons why we use droplet precautions. Now there'll be a little sign that we will place on the door when we have someone in isolation to show that we have someone in isolation. We'll also have our equipment outside of the room. Once you put the isolation gear on, you go into the room, you take care of the patient, you come back out, but you take off the gown, gloves, or mask, whatever it is that you're using, and you destroy them appropriately. Nursing staff with any concerns or questions about the need for isolation precautions should contact infection control as soon as possible. And we can get these signs from the infection control nurse. So they are available. I do have some. TB skin testing. There's been a little bit of a change in the way we do TB skin testing now. We do a 2-step method. I will do a TB skin test, and in 42 or 48 to 72 hours, I will check it. And if it's negative, I will give you another one a week after I read that one And the first one will tell me if you've been around anyone recently who's had TB. The second one will tell me if you've ever been around someone who has TB. Now, after your first year, from then on, we will be doing a TB assessment. And so you won't have to get a skin test every year after that. Handling decontamination, reprocessing, or disposal of soiled or contaminated equipment, laundry, protective clothing, etc. You may be dealing with glucometer care. You need to handle the meter and its system components carefully. Avoid dropping or banging the meter. Protect the base unit from dripping fluid or liquid. Do not immerse the meter or base unit in any liquid. Do not expose the meter or testing strips to excessive sources of heat for prolonged periods of time. Do not store the meter on top of any appliance that may generate heat or in any other location where the meter may be exposed to prolonged heat, such as direct sunlight. And store the meter and test strips in the same environment in which they are used. Reusable instruments, glucometers, are to be cleaned and or sterilized per guidelines. The glucometer disinfection guidelines, the way we clean them is to disinfect the machine between client use. We need to use the supersonic cloth, germicidal disposable wipes, no other solution. We do have precautions in using these disposable wipes. Do not disinfect while blood glucose or control test is inside the meter. Do not get moisture in the test strip meter. Do not spray anything onto the meter. Do not immerse it in liquid. Do not allow cooling of liquid in the touch screen. Any signs of meter deterioration results in discontinued use. It's very important that you do not get moisture in the test strip port because it can cause you to have a misreading. So make sure that you keep it all on the outside. Glucometer disinfection. Put on a clean pair of disposable gloves prior to disinfecting the meter. Hands should be washed prior to donning the gloves. Place the meter on a level surface prior to cleaning. Power off the meter. You want the meter to be turned off. Remove any visible soil or organic material. Use only a supersonic cloth, germicidal cloth, disposable wipe to disinfect the meter. When using the wipe, squeeze off excess cleaning solution or blot on a dry paper towel to remove any excess cleaning solution before cleaning the surface of the meter. Using the wipe, gently wipe the outside of the meter 3 times horizontally and 3 times vertically, and carefully wipe around the test strip port area, making sure that no liquid enters the test strip port. Wipe down the meter display as well. Allow the surface of the meter to remain damp with the recommended disinfecting solution. The recommended contact time for the supersonic cloth wipe is 2-minute contact time. Note, the meter surface should stay moist for the entire contact time. Allow the meter to air dry before use on the next patient. Visually verify that no solution is seen anywhere on the meter at the completion, cleaning, and disinfecting. Ensure that the meter is thoroughly dried after disinfecting. Avoid getting liquid into the test strip. And remember to keep the meter on a level surface prior to disinfecting the meter. Linen handling. On the hose, linen will be handled in a safe and hygienic manner to prevent the spread of microorganisms, which reduce the opportunities for transmission of infection. Linen handling procedure. Linens are defined as bed linens, towels, washcloths, bibs, soft vest restraints, posies, and client clothing, including nightwear. Wash hands before handling any clean linen and don gloves before handling any soil linens. Follow standard precautions for blood or body fluid soiled linens. Hold all linens away from clothing or uniforms to avoid cross-contamination. Avoid fanning or shaking all linen to avoid the spread of microorganisms. Place clean linens on the client's clean chair, dresser, or overbed table, not on any other client's possessions. Remove soiled pillowcase by grasping closed in with one hand and slipping pillow out with the other. Minimize chance of clothing or uniform contact with soiled linen. Apply clean pillowcase by grasping closed end of pillowcase, grasping the pillow through the pillowcase and pulling the pillowcase over the pillow. Do not hold the pillow with your chin to apply a clean pillowcase. Fold soiled linen away from body into a square or ball and holding away from uniform or clothing. Place directly into linen bag or linen hamper with a lid. If clean linen is inadvertently dropped on the floor, it is considered soiled and is handled accordingly, which means that it goes into the dirty laundry bag. You don't pick it up and use it back on the bed. Before we get any farther, we also need to talk a little bit about disinfecting and cleaning equipment here at the hospital that we use every day. All equipment we use should be cleaned and disinfected between clients. The equipment the clients use should be cleaned daily. If we have clients in wheelchairs, recliners, walkers, etc., do you know how to clean them? What is used to keep the bacteria at bay? Cleaning the equipment is our responsibility. It is the same as if a person saw a spill on the floor. The person who sees it should clean it. Usually staff at night take the equipment to the shower room and clean whatever the clients are using so that it can be ready in the morning for service. Disinfectant brush, warm to hot water, and rags are used to clean the equipment. So you do need to brush your wheelchairs, recliners, anything that you're cleaning. This helps break up the bacteria so that you can wash it down the drain. However, staff on another shift can clean up the equipment if it gets dirty at mealtime or at other times. Please don't misunderstand me. I know everyone works hard, but at the same time, we have to provide a clean environment for our clients. And if we don't, the client is the one to pay because of becoming sick. In the long run, that costs more time than keeping him or her clean. And then we're going to move on to disposable infected waste. Hazardous waste disposal is the responsibility of the Environmental Services Department. Waste material will be designated as such by nursing personnel by placing in color-coded liners of low-density polyethylene at least 3 milliliters thick. Waste is properly bagged in red liners and tied. Bagged infectious waste is deposited in infectious waste containers by nursing personnel. Example: remove soil linen with non-gloves after handling a soiled linen. Remove. What I meant to say on the linen part, I had forgotten, that you want to remove the soiled linen with non-gloves. After handling soiled linen, remove the gloves and wash your hands before touching the clean linen. This will prevent cross-contamination. And then we're moving on to hazardous waste disposal and how we take care of that. Waste material is designated as such by nursing and laboratory personnel by placing in color-coded liners of low-density polyethylene at 3 milliliters thick. Waste, which could include sharps, needles, scalpels, broken glass, razors, single-use items visibly contaminated with blood, like dressings, gloves, feminine hygiene products, discarded pathologic waste, unused blood, extracted teeth or tissue samples, and other soiled items determined by the RN on duty to be contaminated or potentially infectious. Items used by the client in an attempt to harm him or herself. Single client used items soiled with feces from a client with infectious diarrhea or infectious sputum, say they had TB. Single-use items like dressings, chucks, NG tubes, IV catheters, urinary drainage bags, oxygen tubing, and suction equipment. During all handling, cleaning, and decontaminating procedures, personnel practice standard precautions. So during all handling, we want to wear rubber gloves and smocks to protect our clothing. As soon as feasible, after removal and disposal of their gloves, employees wash their hands with antibacterial hand cleanser or soap and water. Eating, drinking, smoking, applying cosmetics, and handling contact lenses are prohibited during handling and storage of infectious waste and the cleansing of container, the holding room, and the van. Contaminated waste is properly bagged in red liners and tied, and bagged contaminated waste is deposited in the contaminated waste containers by nursing. Biohazard labels are affixed to all containers of potentially infectious materials. These include containers of regulated waste, refrigerators and freezers containing blood or potentially infectious material, containers used to store, transmit, or ship blood or other potentially infectious waste materials, except when substituted with red bags or red containers like sharp containers or garbage. Individual containers of blood or other potentially infectious materials that are placed in a labeled container do not require individual labels. Contaminated equipment must be labeled, if not in a container, which is labeled. Sharp items used for nursing procedures, including needles, lancets, scalpels, and similar items, are handled with extreme caution. Route of transmission for bloodborne pathogens may be used by a client to harm themselves or others. Medical services and nursing are responsible for the safe use and disposal of these items. Whenever a sharp item or instrument is used during a nursing procedure, nursing is responsible for monitoring its appropriate use and disposal. Now we're talking about razors that are used one time and maybe thrown away. I don't know that we use such a thing here at the hospital. I think people shave with electric razors, but still yet we want to make sure that they're clean and put away properly. When sharps are used in a medical procedure, nursing and medical services are responsible for appropriate use and disposal. Nursing monitors the number of sharps used in a procedure and assures that all are safely removed and returned to the appropriate area or disposed of properly. After use, no sharp is recapped or recovered. All sharps used in client procedures at the hospital are single-use items. That means to the CNAs, when you're doing your finger sticks with a lancet, you cannot re-stick the person a second time if you didn't get a blood drop on the first go, right? Sharps are disposed of in appropriately identified impervious sharps containers. Sharps containers are sealed, disposed of, and replaced according to infectious waste management guidelines when they are 3/4 full or 2/3 full. Any exposure to a used or contaminated sharp is reported. The employee follows the guidelines of the policy. Occupational exposure to blood or blood products. Once needles have been used in a client procedure for injection, IV start, they are never recapped or reused. Needles are not handed from one person to another for disposal. If you are the person giving the injection or sticking the finger, you are the one that has gotten out the needle or the lancet. You do not recap and you dispose of it properly. You do not hand it to someone else. Nursing must always use a needle protection device or syringes with built-in safety devices. Nursing may take a small sharps container with them to the area where the procedure will be completed, and nursing is responsible for the safe return of the container to a secure location, or nursing may perform the procedure in an area with easy access to an appropriate sharps container, treatment room, or medication room. Once lancets have been used in a client procedure, blood glucose monitoring, they are never reused. Used lancets are also disposed of immediately after use in appropriate sharps container. All equipment, environmental, and working surfaces are cleaned and decontaminated after contact with blood or other potentially infectious materials. Contaminated work surfaces are decontaminated with an appropriate disinfectant after completion of procedure. When a work surface is overtly contaminated with any spill of blood or other potentially infectious materials, the employees must wear gloves. The spill is absorbed with dry paper towels, which are disposed of in a contaminated waste container. The contaminated area is sprayed with an appropriate disinfectant until it is visibly wet. The disinfectant must remain on surface for the appropriate time frame, and a wet sign is placed in the area, and the floor or contaminated source air dries. When protective coverings, plastic wrap, aluminum foil, imperviously backed absorbent paper used to cover equipment become overtly contaminated, they are removed and replaced as soon as possible. All waste receptacles are decontaminated as indicated in housekeeping policies and procedures. Broken glassware, which may be contaminated, is cleaned up by using mechanical means like a brush and dustpan or forceps. A percutaneous injury or needle stick or cut with a sharp object or contact of mucous membrane or non-intact skin, exposed skin is chapped, abraded, or with dermatitis, and blood, saliva, tissue, or other body fluids that are potentially infectious. This is where something has gone into the skin, and so therefore it is considered a percutaneous injury. Percutaneous exposure, which occurs through the skin. Non-percutaneous is exposure which does not occur through the skin. Occupational exposure, exposure to blood or blood products which occurs while on the job. Prophylaxis, treatment or intervention used to prevent potential disease. And OPIMs, which are other potentially infectious materials. Those are the definitions that you need to know. When an occupational exposure incident to blood or blood products occurs, the employee is given access to confidential evaluation and follow-up. When a percutaneous occupational exposure to blood or blood product occurs, the employee completes an employee incident injury report and notifies his or her immediate supervisor in the infection control department. The employee incident injury report includes documentation of the routes of exposure and circumstance under which the exposure occurred. The source or client involved is to be identified by client number in this report, to not use names. If the incident needs to be evaluated by a provider, laceration, a human bite, for instance, the employee should be evaluated by an outside provider, a personal provider like your own doctor. You can go out to the emergency or urgent care provider as soon as indicated. The exposed employee is responsible for notifying the outside provider that the evaluation is necessary due to an occupational exposure. A copy of the incident injury report is placed in the exposed employee's health file, and the employee health files are maintained in Human Resources Department, and we keep these for at least 30 years. The source is informed of the exposure and asked to consent to testing his or her blood for Hep B, Hep C, and HIV as soon as feasible after the incident. Ideally, this occurs within 24 to 48 hours of the incident. Counseling and consent for HIV testing is completed according to current Wyoming State Hospital policy and procedure. If the source refuses consent, which they can do, infection control and/or the involved employee may request that the hospital establishes his or her competency to consent. If the source is found not competent to give consent, his or her attending psychiatrist may grant consent for the blood tests. Blood contains the greatest proportion of infections, blood-borne virus, but the risk for transmitting is extremely small. Hep B, immune, no risk. non-immune, a 6% to 30% from needle, stick, or cut exposure, contract the virus depending on the amount of antigen in the client's body. Hep C has a 1.8% from needle, stick, or cut exposure to contract the virus. And HIV has a 0.3% from needle, stick, or cut exposure contract with virus, a 0.1% from eyes, nose, or mouth. So the risks are fairly low in those particular situations. If the patient is found competent to give consent and the source still refuses, the exposed employee will be considered for possible treatment per PEP guidelines from the Center for Disease Control. If the source has had Hep B, C, or HIV testing within 6 weeks prior to the incident, testing will not be repeated. If the source is known to be infected with Hep B, C, or HIV, testing will not be repeated. However, if the source is known to be infected with Hep C, the exposed employee will be advised to seek provider evaluation, personal or urgent care provider within 2 hours of the incident. Current Centers for Disease Control guidelines recommended that known HIV exposures be rapidly evaluated for post-exposure prophylaxis. The exposed employee is responsible for notifying the provider that it was an occupational exposure. The results of this testing are forwarded to the Infection Control Department and filed with the Incident Injury Report in the Employee's Health File in the Human Resources Department. Results of this testing are made available to the exposed employee. The exposed employee is informed of the confidential nature of this information. The exposed employee is advised to have baseline blood tests drawn for hepatitis B, C, and HIV as soon as feasible after the exposure. Ideally, this occurs within 24 to 48 hours of the exposure. Follow-up testing is advised at 3, 6, and 12 months after the exposure. The exposed employee has a right to refuse this recommendation. If the exposed employee agrees to testing, he or she has a test completed at the contract provider laboratory. The contract provider is to be reimbursed through workers' compensation. It is not to be billed to the Wyoming State Hospital. The results of the exposed employee's testing are kept confidential and are maintained in his or her employee health file. Files of exposed employees are maintained for 30 years post-exposure. The exposed employee may request that laboratory results be sent to his or her personal provider. Recommendations for vaccination of the exposed employee against Hep B are as follows. Unvaccinated employee exposed to Hep B antigen, positive or unknown source, initiate Hep B vaccinations. Vaccinated employee with adequate Hep B antibodies, no treatment, regardless of source or antigen status. This is saying that if you've already had a hepatitis B, that we need to have a record of it so that we can see that it's been done. But we also offer the hepatitis B series to you if you haven't had it done. Vaccinated employee with inadequate Hep B antibodies exposed to known HBsAg, positive or unknown source, Hep B immune globulin for 2 doses, or HIV for 1 dose and initiation of revaccination of Hep B. Vaccinated employee with inadequate Hep B antibodies exposed to a known SBsHg negative source, no treatment. At the time of the initial lab test after exposure, the infection control nurse provides the employee with a letter outlining dates for further testing if needed. The risk manager reminds the employee of 3, 6, and 12 months post-exposure recommendations for continued follow-up. If the employee terminates employment during this period of time, the initial letter is a reminder for the follow-up lab test. If the exposed employee leaves employment at the Wyoming State Hospital, the exposed employee is advised to continue with follow-up. The exposed employee is responsible for informing Workmen's Compensation of his or her change in status to assure continued coverage. The exposed employee is entitled to post-exposure counseling. The exposed employee may choose to work through his or her person provider for a reevaluation and treatment of incident. If the occupational exposure to blood or blood products is non-percutaneous, the exposed employee is advised to complete an incident injury report and follow the protocol for submission of the report. Exposure to intact skin does not require a follow-up. To enhance the protection for staff against the acquisition of a bloodborne pathogen, employees are offered the Hep B vaccine series. The 3-shot series is offered free, with immunizations occurring 3 months and 6 months from the initial vaccine. Employees have the right to refuse the vaccine with no adverse consequences to their employment. The employee must sign a consent prior to receiving any vaccine, and I do have those available. Reporting to Infection Control Office, nursing staff, physicians, nurse practitioners, and all staff are responsible for reporting known or suspected infections to the Infection Control Coordinator. Prompt reporting of infections improves client care and allows the Infection Control Coordinator an opportunity to accurately track infections and respond to client staff needs. These are the references that we used for this presentation. The CDC and Occupational Safety and Health Administration have a lot of information that they love to share with people. And so if you want to get in contact with them, just let me know and I will help you. If you have any questions, I will be available to answer your questions. Evaluations, I'm asking that you please fill out evaluations and put them in the box to give to Peggy. And I appreciate your time. Thank you very much for attending this presentation.